QEH Pulse Radio Show every Monday, 11 a.m. till 12 noon with Shane Seeley. Let's see what happened in our last episode. The Pulse Radio Show brought to you with the kind compliment of MedSafe Medical Supplies.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials. To all of our Q listeners joining us for what is another edition, a live edition of the Pulse Radio Show. I'm Shane Seeley, Communications Specialist with the Queen Elizabeth Hospital. And as you know, this is the space where we use to tell you everything that is happening at our hospital, all of the developments, all of the very latest. Those of you who would have questions for us week after week, we answer them right here for you when you call us on either 4341007 or 4341070. Back with you live this week after being on a little break. I had a short vacation, but it's always good to be back because we love to keep this connection with you, our valued listeners, our customers really, those of you who use the Queen Elizabeth Hospital. We got a lot to talk about today as well. Another topic. I remember the last time we were live, we were speaking about this new collaboration between the Accident and Emergency Department, the Queen Elizabeth Hospital by extension, and a number of the external providers of emergency services. You may go to Sandy Crest or the Coverley Medical Center. There are a number of others. We're now partnering with them to ensure that we can fast track what we do in terms of when people go to these facilities, they may feel they're suffering from a heart attack or something of that nature, and there's now a specific treatment path that allows a better survival rate for those who would go that route. We've had several meetings. I understand that things are now in place for that flow to happen. And funny enough, though we were talking about something very different today, we were talking about heart failure still. And that is definitely connected with that. Dr. Dawn Scantlebury, our head of cardiology, and really one of our leading cardiologists on island, she was in several of those meetings as far as creating that partnership. So it's good to have you here, but we were talking about a different memorandum of understanding this time around, and we will get to that. But good to have you back.
Good to be here, Shane.
Actually, let's start there where we ended the last time this show, the Pulse Radio Show, was live. Mm-hmm. You are a part of that thrust, working with our head of accident and emergency, Dr. Cruikshank, and of course Dr. Brian Charles as well, and some other providers in the private sector to ensure that that partnership really works for the benefit of patients who visit maybe not only the accident and emergency but some of those private medical facilities. Talk a bit about that partnership, just to remind our listeners the direction that we're going in terms of dealing with people coming in with what could be a heart attack or some heart condition.
Okay, so I'll give you a little background. So that the idea actually came out of the cardiology department and the cardiologists on island. a few years back. So, every year the Barbados National Registry of Non-Communicable Diseases, so the BNR, looks at our data, and there's actually a professional advisory board where they meet with the cardiologists, internists, and other stakeholders in these NCDs and present data even before it comes to the point of going to the public. And over the years, it's been very disconcerting how our heart attack outcomes are not meeting targets. So, say for instance, the first one of these meetings I attended, the mortality from heart attacks in Queen Elizabeth Hospital, and this is patients presenting to the hospital alive, because there's also the cadre of patients who die before coming to medical attention. The mortality was around 35%, 35 to 37%, and coming out of that, we had a series of meetings to determine how best we could go about decreasing our heart attack mortality here in Barbados. So you may have heard of our heart attack or STEMI mortality reduction project, and we did it. We've been doing it in a systematic manner. I changed my terminology there and said we did it to we've been doing it, because it's an ongoing process, and
Indeed.
quality improvement process is going to be ongoing. We looked at all the different areas of targeting heart attacks, and look at the home. We look at presentation to primary care centers, urgent care centers. We looked at presentation to the emergency room and management within hospital. So one of the things that we did was we partnered with Heart and Stroke Foundation, for instance, to talk more about what the patient's response to heart attack symptoms are. We did a survey through the University of West Indies and Professor Dwayne Devonish, looking at what the current perceptions within the public eye and the community is on heart attack symptoms. And when it came to the urgent care centers, one of the things we said was, well, patients present to urgent care centers, the Sandy Crest, the Coverley, the FMH, the urgent care at the estates. These centers are staffed by qualified physicians, in some instances physicians who are consultants in the emergency medicine department. So they come to these centers, they get their diagnosis, and then there's a delay. So one of the concerns, one of the determinants of mortality in heart attack is how quickly that management is
time is of the essence.
Yeah, so we say time is muscle, actually. So time is muscle, because a heart attack is damage to the heart muscle because of a blocked blood vessel. So the quicker you can open up that artery, the better the outcomes are. So when you look at international data and research, if you can open up that blood vessel within 3 hours, your outcomes are best. Obviously, if you have your heart attack, if you happen to walk into the emergency room and have your heart attack while there and get the blood vessel opened immediately,
you save muscle.
You're almost like you didn't have a heart attack at all.
Okay.
But the longer you are from the onset of symptoms, the more damage there is, and the higher the likelihood of death and heart failure. We'll come to heart failure a little bit later in the show.
Right.
But one of the things that we're trying to do with making sure heart attacks are treated in a timely manner is to prevent this epidemic of heart failure that we have in the island. So one of the things that we said, well, if a patient is presenting to an urgent care center and they have doctors there, they have monitors there, why don't we just treat the patient at that point with the drug? The problem is the drug is $3,000 a pop.
Wow.
It's a lot of money. So, and I know the Barbadian public is not aware of just how much money Queen Elizabeth Hospital spends on every single disease process. But, that's what happens when they come to the emergency room. You come, you get your ECG, it shows ST elevation. The ECG is the electrocardiogram, which is the heart tracing. It shows a specific pattern, and that pattern is what signals to us that we need to give this drug.
I want you to pause on that $3,000 drug, because I want our listeners to get that picture and to understand how expensive this undertaking is, but it's a critical undertaking, and
It's a
one that
critical
a
undertaking.
burden that the government and by extension the QH has decided to take on to try to save lives. We do have a call. Let them get in very quickly, and we continue that conversation just after the administration of that $3,000 drug, and you can tell us about the name, exactly what it does. Good morning, caller. Welcome to the Pulse Radio Show. How can we help?
Good morning. Peace be unto each and everyone. This blessed Easter. Easter season. Sorry about that.
You're on the right track. You're on the
I
right
have
track.
a
How you doing?
question. I'm thankful. I haven't a feedback though.
I think it's because you may have your radio on still.
No,
No, you don't?
I am outside.
Oh, okay. I don't know what happened in then, but we can hear you loud and clear.
All right.
All right.
I want to ask a question, and I want to thank someone. I want to ask the goodly doctor that this person is a doctor, right?
Dr. Scantlebury, yes,
Right.
our head of
Dr.
cardiology.
Scantlebury, good morning. Peace be unto you. You have a distinguished guest. I want to know if heat, like hot, being outside in the hot sun, if that can cause a heart attack.
Okay. Dr. Scantlebury.
Let me work through the pathophysiology in my mind. So, being out in the hot sun and being exposed to dehydration and significant dehydration can lead to various
heart attack.
things. So, you can get something called a heat stroke.
Okay.
You can get abnormal heart rhythms, which can lead, if continue for a period of time, it can lead to heart damage. If you are significantly predisposed and you are quite dehydrated and overheated, you can have stasis of blood in the blood vessels that can ultimately lead to a heart attack, that increase in stress. So overheating doesn't on its own lead to a heart attack or being out in the sun for too long. There are a series of steps whereby one would go through that may lead to a heart attack in someone who is predisposed. So we're still looking at someone who is very predisposed and then
well, explain predisposed, because some people might not understand when you say predisposed. So that is somebody that
that's someone who may have
hypertension,
high blood pressure, diabetes, and high cholesterol, smoker, that kind of thing, who might have cholesterol plaque in their blood vessels. That then, in the stresses of excessive heat exposure, may go on to have rupture of that plaque and then a heart attack. So, there are a lot of time points that you can exit from the process by which a heart attack occurs. So hydrating up, etc. But if you are predisposed, it is the wisest thing to do to make sure your body is comfortable. So don't become overheated. But I'm talking about if you become dehydrated, if you're exposed to heat for a prolonged period of time such that you develop that overheating. But just going out in the sun, if you have heart problems, it's not necessarily a big deal. It is the degree and length of exposure.
All right, Shane.
Yes, please.
Please allow me. From last year, I had to travel to NIS. And I'm sorry that I didn't take this lady's name. Now, I have a problem with my hands, especially right hand, from the shoulder right down, and I have a trigger finger, and then I damaged my pointy, we will call the pointy finger, the warning finger that your parents will warn you with. So I have a problem sometimes in writing. And this lady, whenever I go, she's on the right hand side when you come through the door on the right. She's very pleasant to me, and I want to say I didn't get her name, but I want to say thank her so much, because I started, but I had a problem, and she filled the form out for me. So, ma'am, I guess a lot of people listen to these programs. I want to thank them, and I want to thank NIS, the staff. So thank you all very much, and Shane, Easter season to you, and take care, everybody, and God bless Barbados.
Thank you, and thank you for always calling and sharing your knowledge, because you also know some of the questions to ask. You asking about what would predisposed mean for someone predisposed to heart disease or a heart attack, heart failure, etc. So we really thank you for your contribution today. You stay safe. So back to that conversation as we were getting into not the heart failure side yet, but this $3,000 drug that we support to administer, especially working in partnership with the urgent care medical centers.
Right. So, so the process would be similar to what happens at the QEH. Somebody comes in, they get ECG, the STEMI is diagnosed. You have to make sure they don't have contraindications to the use of the drug. The drug is the category is thrombolytic agents or thrombolysis. The one that we use here in Barbados is tenecteplase, which is a fairly expensive drug. We used to use a cheaper drug years gone by, but the problem is that it is a lot more labor intensive. It requires a 1 hour infusion with very, very intensive monitoring, whereas tenecteplase is more effective and easier to use, and it's the standard of care worldwide now. Okay. So we use this drug, and that obviously is not the be all and end all. This patient still needs to be transferred to hospital for further care. And their $20,000 PCI. So healthcare is exceedingly expensive. But the reason why we do this, and for those out there who are trying to add up figures, etc., we are trying to, 1, save lives, and 2, prevent recurrent readmissions with either angina or something like heart failure. So years ago, someone estimated that a heart failure admission would cost the hospital about $10,000 to $12,000. And the most common cause of heart failure in Barbados is going to be ischemic heart disease, so heart attacks, and hypertensive heart disease, so untreated high blood pressure. And when patients come into hospital, and sometimes we get people that come in 3-4 times a year, sometimes even longer than that. Think of that. So 10 to 12,000.
3-4 times a year. At those figures.
At those figures. Sometimes every month there are some people that we're seeing coming in. So we're trying to prevent healthcare, that excessive healthcare expenditure by making sure patients are treated right up front. So that's where this tenecteplase project came in. We decided that we would push it. So when I first introduced that, I got a lot of naysayers. And this is almost 10 years now we've been talking about this. Okay. One of the things was, we're going to introduce this, maybe what prevents people from taking the government's dollar and then disappearing? Well, the problem is they've just had a heart attack. And we have looked at the problems. We've looked at the downsides, the upsides, and we've kind of put things in place to address them. Like I said, no battle plan survives the initial exposure to the enemy. As things happen, we will see problems and we will address them at that point in time.
Yeah, so 2025 is the year that it got off the ground, and we will see the results. And
we will see how things go.
And hopefully more lives will be saved by going this route, where we get some quicker intervention. Intervention at that point where you're trying to reduce the amount of muscle loss due to the heart attack.
Right.
Correct. Good. So then there's the heart failure side, and that's where our conversation will go, as we have a new relationship to talk about. More to come after this quick commercial break.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Jemmets Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Pulse Radio Show. I'm Shane Seeley, Communications Specialist. My guest today, Dr. Dawn Scantlebury, the head of cardiology at the Queen Elizabeth Hospital. And we were just speaking about one new project and then on to the next. She's been busy creating these collaborations which will benefit our patients who suffer and live with heart challenges. So let's talk about now. We were speaking about that project, and that really speaks to responding to things like heart failure.
Mm-hmm.
So let's get into that conversation, and I know this conversation leads into your next baby, which speaks to developing another great pathway at the Queen Elizabeth Hospital to help deal with heart disease. So let's talk about heart failure and how that comes about and what you're seeing on the ground here in Barbados in relation to heart failure. How prevalent is heart failure among Barbadians?
So I guess the first thing we should start with is what exactly is
heart failure.
So like the caller just reminded us, not everybody has that knowledge. So heart failure is a syndrome where patients present with symptoms either of reduced output from the heart or stiffness of the heart muscle, where you can feel fatigued and weak, and there's fluid retention either in the lungs or in the body. So the heart muscle is weakened, it's not pushing out enough blood. You can, in the acute setting, patients can have confusion, low blood pressure, kidney trouble. That's in a severe acute heart failure. Chronic heart failure often presents with, again, fatigue, but the syndrome where the lungs fill up with fluid, so patients get short of breath on exertion, shortness of breath lying down flat, and they can get leg swelling as well. So sometimes you see people with these big fat ankles and legs, and that could be as a result of heart failure.
Oh.
So
no, and the reason why that struck me is because just last night I saw a gentleman with what some people refer to as cankles.
Cankles.
Yeah, bigger ankles.
Big ankles.
Yeah, and you know, and I got into a conversation speaking about how, as Barbadians, as the average person out there, we need to do everything to take better care of our health, whether it be exercise, eating healthy. The list goes on, to avoid falling into a situation. I understand that sometimes, as you say, there are some people that are predisposed. Some of it is hereditary, but a lot of this can be avoided.
It can be
by living a healthier lifestyle,
right,
and doing all that entails.
Okay, let me go back to the cankles thing. So there are a lot of causes of leg swelling or ankle swelling, and heart failure certainly is the first thing that comes to mind when you go into a healthcare setting, because it is the most significant thing that you need to rule out. Venous disease is another cause. Lymphedema is another cause. You've heard of sleeping sickness, etc. And there are some medications that can increase the risk of it. But for listeners out there, if you have significant leg swelling, especially if it's associated with exertional intolerance, you find that you can't do as much as you used to, and you're short of breath on exertion, you're getting short of breath on exertion, you should seek medical attention. So heart failure, as I had said earlier, the most common cause worldwide is ischemic heart disease, where there are blockages in those blood vessels that supply the muscle of the heart. Hypertensive heart disease is a quick second and maybe exceeding the ischemic heart disease in Barbados, just because of how much hypertension we have. But they're kind of on the same level. Then there are other genetic causes. People may have a viral illness that can lead to damage to heart muscle and can cause weakness of the heart muscle. We call that a viral cardiomyopathy. The hypertrophic cardiomyopathy is a genetic cause, and a lot of other causes. There's a whole list of causes of heart failure, but ultimately all of these causes lead to that syndrome of and constellation of symptoms that I described.
Let's take a pause here. We have a caller. Let's let them get in here quickly. Good morning. Welcome to the Pulse Radio Show. How can we help?
That is great.
Hi, caller. Good morning.
Yeah, good morning, Shane.
Hi, good morning. If you could,
Scantlebury.
yes, if you could please, listen to us. I think you've just turned on the radio.
Yeah, no, I can hear you all.
All right, good, perfect. Talk
My
to us.
thing,
How can we help?
I know that if you're going to get a heart attack, I want to know if that still works. You will put some baby caffeinol and take it, and rather than swallow it. Is that a system that still works? I mean, before you could get to the doctor, you would do that.
So, one of the initial drugs that we give people when they're coming in with a heart attack is aspirin, yes. So it is not an alternative to presenting to hospital because chest pain has a lot of different causes. It can be caused by a heart attack. It could be a pulmonary embolism or a clot in the lung. It could be something called an aortic dissection or a tear in that main vessel that comes off the heart. And if you have an aortic dissection, you really don't want to be taking too much aspirin because that's a blood thinner. So one thing you probably should do if you're having chest pain and there's concern for a heart attack is to call the 511 number and speak to someone and have a conversation about what the appropriate response should be.
Yeah, but another thing, Dr. Scantlebury, we're looking at the urgent care. Suppose that right now I live in Lower Bernice. Mm-hmm. So they down to St. James and they have a serious heart attack would be serious.
You go to the Queen Elizabeth Hospital.
Right, so that's why this system was set up.
That's why I say when you drive, you could. My suggestion is if you could all approach FMH.
Sure. So it depends on where you live, really.
And so when we say urgent care center, all urgent care centers are those emergency type centers that are open overnight to take patients. So even though urgent care at the estates or whatever, they have that in their name, FMH, Sandy Crest, Queen Elizabeth has an emergency room. But all of these centers across the island are called urgent care centers. That is the term. That is what they're called. So they may not necessarily have it in their name, but that's what they are. They're urgent care centers.
I just say would ask those two questions. Because you say I know urgent care is in St. James. So I know that if you're really urgent and you have a serious heart attack, they don't to St. James. As you say, depend on where you are. Then to go to the hospital. I was one that when you mentioned the shortness of breath and the smelling, and my wife would tell you I went to the hospital. First thing that took me up on the wrong ward, I spent 8 hours up there. That was at the A&E. I could have died up there. You know what I was saying? They have natural causes. So going to the hospital is a serious thing. Mm-hmm. And then they took me back down. And I was down on the floor, keeping all kind of, and the doctors, none of them noticing. My wife would tell you that. 8 hours I went through that day to get told I was on the wrong floor. But I managed to get over that because I know to get my immune system up. And instead of using the fan, I would come. Actually, they still have me on. But my wife would tell you that had me so good. I could hardly put on a mask now. And when I have delayed appointments, I don't go to them because I say just a breath away from death. And I tell them that I cannot put on a mask. I'm not going anywhere. My wife would tell you that.
Yeah, we always advise that anyone coming to the clinical setting at the hospital would wear a mask. In some cases, there may be an exception, but that is the very rare case.
Right,
you would have to speak to someone there, but it is good to hear, though. I mean, you spoke about your challenges there at the QEH, but it's good to hear that you can speak to us.
Challenges, but I managed to get over it. Thank God.
Thank God, and thank the doctors at the Queen Elizabeth Hospital.
Well, I would say the doctors, I know it is me that got over it myself. By building my immune system, when I went on the doctors, they were dead. And that would have took me up on the wrong 40 hours.
You know the hospital is still the same place that you left, though, and that you got the treatment.
Well, I didn't know if I got the treatment. I know I tried to treat myself to get over it.
You know how you know? Because you're here to talk to us. Listen, We can't pretend.
Anyhow,
we can't do this
I
alone.
don't scare there. You keep the good work up, huh?
Thank you very much, sir. Always a pleasure.
So he does raise a good point. I think maybe some people mistake that terminology, and maybe we should find a different one. It's just worldwide. That's what they're called, urgent care centers. It's just urgent. That particular entity has it in their name. But we mean that the four entities: Sandy Crest, Coverley, urgent care, and FMH. So the thing about FMH is that FMH is practically right next to the hospital, so people would
just come to the hospital.
Yeah. And in any emergency setting, if the ability to present to the Queen Elizabeth Hospital is there in a timely manner, one should do that, especially if you're thinking you're having a heart attack, because ultimately that's where patients will be sent. So you go to Coverley, you get a heart attack, they're calling 511 as they're administering the drug, and they've already called the cardiologist on call at the hospital to ensure that it's the appropriate diagnosis. So they're not doing it on their own, they're still involving the hospital. So what they're doing is doing this on behalf of the Queen Elizabeth Hospital. This is not like them, we're just giving the drug and telling them go out there and do it. This is them doing the drug.
It's a part of the treatment path
on our behalf, so that we can make sure that it's a more effective therapy, as having been given 2 hours up the line or whatever.
Saving heart muscle and saving lives for sure. Remember those numbers that you can call with your questions as we speak about heart failure and the response and improving what we do at the hospital to deal with these situations. 434-1007, or you can call 434-1070. You can also use the 434-1007 to send a WhatsApp with your question. If you're a bit shy but you just want to get some information from Dr. Scantlebury, the head of cardiology at the QEH, those are the numbers that you can use. So as we speak about heart failure, how big is the problem?
So it's one of the most common admitting diagnoses to hospital, really and truly. So I'm talking to one of the chief of medical records the other day. One of the most common presentations is chest pain. And chest pain, as I said, can be caused by all sorts of different things, not just heart attacks. Heart failures are fairly common underlying cause of chest discomfort as well. But then once you go through the process in the emergency room of being evaluated for that shortness of breath or chest discomfort or something, heart failure ends up being one of the diagnoses a lot of the time.
Okay.
And when you look at patients who spend some time in hospital being worked up, the ones who take up a lot of our resources as far as being investigated with echocardiography, etc., and then they get discharged and then they're readmitted a few weeks to a few months later because of recurrent symptoms. That's one of the reasons why it's one of the things that is in hospital more than anything. I think maybe a diabetic foot is probably
the other one.
The other big one, but heart failure is one of the big diagnoses, just because of all of these readmissions and sometimes how long it takes to sort out.
Okay, so when we come back from this commercial break, as the Pulse Radio Show is brought to you by MedSafe Medical Supplies Limited, your trusted place for medical supplies. You need to go there and get and see all of the good things that they have in store. You can check them out for sure. But when we return, we're going to talk about this MOU, this new Memorandum of Understanding with the Heart Failure Association in the U.S.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
We're speaking about heart failure today on the Pulse Radio Show and the response. It's one of the leading presentations to the QEH, something that Dr. Scantlebury, our head of cardiology, sees daily. And she's been developing a number of mechanisms to respond to this trend. So one of those mechanisms, partnership with our friends over in the US, the Heart Failure Society of America. Talk a bit about this budding relationship.
Okay, so one of my childhood friends, actually, Monique Robinson, who is a cardiologist in the US now.
She's a Bajan, though.
She's Bajan, yes.
She's Bajan.
Yeah, we grew up together. We went to piano lessons and church and everything together.
Wow.
So she graduated medical school here at UWI, but then she went off to England to do her PhD or DPhil on a Rhodes Scholarship, and then ultimately ended up in the US doing cardiology. She did heart failure transplant, so advanced heart failure is a subspecialty of cardiology, just like there's interventional cardiology. That's what I did. And when we graduated our cardiology training, she had approached me on various occasions to see how she could give back to home, because she is now in the US, working in the US. And we had a conversation about heart failure in Barbados and how we could target the scourge, as it were. Because sometimes, you know, if you talk to anybody who works in internal medicine, they will tell you how much a scourge this heart failure is. So the one thing that arose recently is that the HFSA, the Heart Failure Society of America, which is a society that of heart failure specialists who are, is an academic society. They actually have a training program for people who are not heart failure specialists, but to train in management of heart failure and optimal medical therapy of heart failure. At the end of it, there's a certification that's administered, or the certification that people get, and we had a discussion about how we could get our staff here in Barbados adequately trained in heart failure therapy. So heart failure has different ways of approaching it and different management options. So one of the things that you have to think about when somebody first comes in with their first diagnosis of heart failure is, what is the cause? And then, you look to see if you can reverse that or target that cause to see if you can make their heart failure better from the underlying cause viewpoint. And then there's a kind of like a package of drugs that we use. We call it the pillars, actually, of therapy now, because there are 4 core drugs that we use for heart failure with reduced ejection fraction. Ejection fraction speaks to how the heart squeezes, but then there are patients who have a different type of heart failure where the ejection fraction is preserved, and it's just that their heart muscle is stiff. So there is a different set of therapy for that type of heart failure. And then there are ways of approaching how to administer those drugs, how to introduce them, or contraindications, indications, how to increase, how to titrate meds. And then once patients go through that process, that initial process, then there is more advanced heart failure therapies. So initially, when patients come into hospital a few times, it's because we haven't quite gotten them under control. But then you'll have the patient with heart failure who has been stable for a while, they're doing well, they're living their lives, and then they start coming back into hospital again. And you find that what was keeping them, what meds were working for them before, are no longer working. Again, you have to work them up to find out what is causing that. It could be that they've developed coronary disease or something else is going on. But sometimes whatever is underlying that heart failure diagnosis has progressed, and we're having a progressive decline in their heart function. And this is now your advanced heart failure patient. In Barbados, all we have available for these patients is medical therapy. In the US and other first world or developed countries, as it were, then that's the point at which they start looking at advanced heart failure therapies such as heart transplant or ventricular assist devices. Again, that's not something we can even conceive of using in Barbados, because a ventricular assist device is we're speaking of millions of dollars. Heart transplant.
So again, the cost factor is in there.
It's prohibitive.
Okay.
For our setting.
All right, hold that thought, Dr. Scantlebury. We have another caller, just very quickly. Let's go to the phone lines. Good morning, caller. Welcome to the Pulse Radio Show.
How are you doing?
Oh, hi. How are you doing, man?
Man, I'm blessed, thanks. Great to hear from you.
Good. You have a question for Dr. Scantlebury?
3 questions, actually.
Wow.
Excuse me. Sorry for that. My first question has to do with the aspect of why hasn't the hospital patented a tea based on our rose and the Barbados hibiscus and our Bajan foods which are healthiest for high end protein of arginine, where we know that arginine has a pathway with nitric oxide that leads to the heart being very selfless and so very good, being very functioning well.
Okay, so let's deal with that question then. Let's deal with that question in terms of patenting. Is that something? This is trending, it sounds like to me, to the herbal side of things. I know doctors normally say, they're specific medications, and we deal with that and not necessarily these natural remedies or quote-unquote natural remedies.
I'll speak to natural remedies as it relates to the heart. A lot of natural remedies, and I will say the most natural remedy I'm going to recommend to anyone is fruits and vegetables, more of a plant-based diet, and exercise as far as reducing your cardiovascular disease risk. So let's take arginine, for instance. Arginine is a naturally occurring amino acid in the body that is in the pathway for the development of nitric oxide. L-arginine is an enantiomer of arginine that is given, that you can get in a health food store, and given large doses of L-arginine can lead to an increase in nitric oxide production soon after administration of L-arginine. The nitric oxide, because I've spoken of nitric oxide but I didn't say what it does. Nitric oxide leads to dilation of the blood vessels, and it's produced in the lining of the blood vessels to lead to that vasodilation. Good vascular health relies on production of that nitric oxide. And what leads to good vascular health? A good diet and exercise. So in mainstream medicine, L-arginine can be used in patients who have severe angina, say those I've used drugs on and they're still having symptoms. Sometimes you can give L-arginine in high doses to help improve the exercise capacity,
right,
so that they could exercise more, to help improve the function of their endothelium, that's the lining, so that the lining can produce more nitric oxide so that they can do more. But ultimately, it's all about exercise and all about vasodilation. There are a lot of drugs, drugs, but also foods, etc., out there that are associated with improvement in that endothelial function. But when you look at their overall what they overall are. It's those fruits and vegetables that we are all recommending. So rather than looking at these things and picking out one of the many molecules within that that vegetable to say, well, we need to go and pull that out and administer that from the health food store. As a prevention specialist, I often recommend to people that you look at changing your diet to be more plant-based, increase your physical activity rather than going and spending hundreds of dollars on L-arginine, especially since it is not evidence-based to lead to increase in longevity. We do have very good medications that are associated with reduced mortality, increased longevity, and decrease in symptoms, and those come through randomized control trials that are done on tens of thousands of people, hundreds of thousands of people. The other thing that you mentioned was hibiscus. And I will say, as good as it tastes and as good a tea as it is, there isn't anything specifically within hibiscus that has been proven to lead to longevity. But again, if you are the kind of person that's drinking hibiscus tea and eating vegetables, etc., you're probably the kind of person who is focusing on a healthy diet and focusing on exercise, and your outcome is probably going to be better than the other person.
I'll allow you one last question because we still have a
problem.
lot to talk about here.
Let me thank Kermit for taking my call. You know what I do? I follow the 3 natural laws. I follow exercise, sleep, and
good diet.
and healthy eating. Yeah, thank you. But what I find I do, I take a lot of tomato. I'm eating a lot more tomato paste out for my heart, lycopene. The good carotenoid that stops a lot of cancer, especially heart cancer, that kind of thing. And what I do is that I mix the hawthorn as well, that wonderful herb for the heart, with the hibiscus. And I will take that on mornings early with my B vitamins that are for stress, and it will give me a heart boost when I go out then to do my exercise. I'm gonna run throughout the day. So I just thought that I would, share and be able to help those who, especially a good doctor who so eloquently was able to give such a great explanation just so to answer my question. And I want to thank you. So I would just have to, basically ask, why isn't it that Barbadians, and especially the medics, that isn't a place on the way in the ambulance to the hospital where they're given hawthorn tea, so that in the time that it takes for them to go to the hospital, they're not losing time to muscle because they're given the tea and the medications as well as the natural supplements that the good doctor mentioned that will help on the way to heart care and caring about your heart. God bless. Thank you. Bye-bye.
Well, that's Scantlebury. I think he's leading back to now your first project.
Aspirin.
Well, outside of the aspirin, I was thinking about, when someone
the
comes in.
place,
Yeah.
So everything that we use in medicine has been studied rigorously, as I said, in tens to hundreds of thousands of patients. With it, without it, what is beneficial. And I can't speak to hawthorn. Hawthorn doesn't really have a role to play in cardiovascular management, or at least not at this point in time. All right, so where were we in terms of heart failure? I was talking about advanced heart failure therapies.
Yes.
So heart transplant fact. So we're not at that point. So it is very important to try to prevent our patients from getting to that point. So over the years, every time a new drug is discovered or developed that has been shown to reduce heart failure mortality, it's greeted with enthusiasm from the cardiology community because of the deadly end result of heart failure. So all of these drugs reduce progression to that end-stage heart failure. So Dr. Robinson, as a heart failure specialist, would deal with the transplants and the VADs and the more advanced heart failure patients. And the onus is on us in internal medicine and general cardiology and primary care to prevent patients from getting to that point. And where this collaboration comes is that this certification that they do comes at a cost to people within the U.S., and they have offered it to us for free to a certain group of us. So what we're trying to do is to train up some staff, some junior doctors, cardiologists, and nurses as well, and the pharmacists, and we're training them with a view to see if we can develop a heart failure service, which we've been speaking of for years, but because heart failure is such a big problem, there is this difficulty with trying to figure out how are we going to do this. Are we going to do an early access heart failure clinic? Are we going to do a more advanced heart failure service where those sicker patients we take in hand to try to reduce those admissions? Different ways of approaching it, but what we're trying to do is at least get our staff trained up so that we can then put things in place that we can put the service in place.
Okay, with this memorandum of understanding, what do you see happening over the next few weeks, a few months? You could tell us a bit about that after we come back from this call. Good morning, caller. Welcome to the Pulse Radio Show as we speak about heart failure and the response at the Queen Elizabeth Hospital. How can we help?
Good morning.
Hi, good morning.
To all staff at CBC, especially to Kimberly, and also to, CBC of having this educational health program to everyone, and to Shane Seeley. I won't even tell you who I am, to be honest with you, but I believe that your work colleagues at CBC is very proud of having you on the show, to entertain with your good program that you are having, along with is Dr. Robinson, right?
Dr. Scantlebury today. She was speaking about Dr. Robinson, one of her childhood friends, and now really a colleague of hers who is really helping us here in Barbados to step up how we're dealing with heart failure.
Very big welcome to her. And I'm listening to her. I just come in short and hearing this program on, but she's very profound, and in her profession, and the good advice that she's putting up there to the public. And I'm very happy to hear, very well explainable to us, the public. So keep on the good work. And also, I wanted to say a big thank you to Dr. Kirk Miller. Share, you know who you're speaking to. They're Angeline.
Oh, hi, Angeline. How are you doing?
Hi, good, sweetheart. So I want to say a big thank you to all the staff, over there. Again, and Shane, you keep on the good work. It seems that you belong to that field for a very long time. Let me tell you something. You're already handling your program, your profession very well.
Thank you very much. Thank you very much.
So you keep it up, and God will continue to bless all health workers over there at the hospital. And I want to send a big shout out to Michael Grant. We're calling on the hotline.
Yes,
He's done it right, and people like him over there and others who work on that to make sure that persons get their medication delivered on time.
Yes.
So healthcare workers to all across the board of Barbados, Joseph, you all keep on doing the good work over there. It's limited resources, but we try to make it do. You creep before you walk. Things were put in place, and it's happening both here.
Yes, thank you.
Have a good weekend to all of you, Shane, and
week.
to Dr. Scantlebury.
You're rushing the week. We can have a good week before we get to the weekend.
But I'll put it in 8 now.
Thank you very much, though. I appreciate it.
I'll sit there.
All right.
All right, too.
So returning to the MOU. So
yes.
As far as the heart failure service, Dr. Adaremi Soyombo, who is one of my colleagues at the hospital, is spearheading this whole initiative as far as figuring out how best we're going to go about decreasing those hospital readmissions. And I'll tell you, if you go to the heart failure literature, it's so important. It's a whole field of specialty, and it's always a conundrum and always a big area of discussion. How best is a health system? How does a health system decrease the scourge of heart failure? And so, from my viewpoint, one of the things that I would ask our public is to understand the basics of self-management of heart failure, actually. And obviously, when we introduce a heart failure service, whenever patients come into the clinic, etc., we discuss what best to do. But on the air right now, one of the things we recommend patients do is decrease the sodium in their diet. Take your medication. Heart failure.
Leave out the salt.
Leave out the salt and take the medication. Because one of the important things about these drugs is that they help maintain your blood pressure. They decrease the strain on the heart to kind of allow the heart to breathe and prevent progressive worsening of symptoms. Something else people can do is be aware of when symptoms are starting to develop. Weigh yourself on a regular basis, 2 to 3 times a week, or even every single day, because that sometimes can give you an indication that you're starting to retain fluids.
Your weight.
Okay. So a liter of fluid weighs a kilogram. So if you are having a heart failure exacerbation, one of the earliest indications is that your weight has gone up. Even before you start to see the swelling in the legs or start to get short of breath, people start seeing that the weight is starting to creep up. So half a pound, and then over a period of a week, if that weight has gone up, we can target that with increasing the diuretic dose and prevent an admission.
Yeah, I think you're going to have to go through a to-do list or a checklist of things that people can look out for, especially when it comes to symptoms leading to a heart attack or heart failure. We have another caller very quickly, our last caller for the show this morning. Good morning, caller. How can we help?
Yeah, good morning.
Good morning.
Good morning to you, Shane Seeley and Dr. Scantlebury. But I was just listening to another radio station and heard a lady calling, crying for a friend of hers at the hospital since last Wednesday with a suspected heart attack, and she's still in casualty, sitting now waiting to be seen by a doctor. Is this really the norm? Is this right?
Well, I can tell you that's not really the norm, and another discussion that I had this morning, because I think when people are in accident and emergency, they would have got that initial assessment seen by a doctor and would have received a level of treatment that would have stabilized them, and then they're still in accident and emergency for a few days. I think there's a misunderstanding that because they're not advanced to the ward, that they're not being treated, but the accident and emergency now expanded. It has some subcomponents, and you're there waiting to be transferred to the ward, but you are really warded already in accident and emergency before you are further warded on whatever ward you
for bed light.
Say again?
You're waiting for bed light.
Exactly. And Dr. Scantlebury can explain more on that.
And she started crying for her friend. She said since last Wednesday, and all no. And she asked anybody if this could be real. So I want to know. I would like somebody to really check that, because it broke my heart too. That is why I called.
And I'm glad you called, because I already got the message, and I intend to.
Oh, you did get it? Oh, thank you.
Yeah. I intend to speak to that very shortly, because when someone is not well, we can understand the feeling and the outpouring and the sensibility that and the sensitivity, I should say, that you would have to those situations. But there's a fuller picture in terms of the pathway and the treatment path that needs to be explained, that is not often understood, especially by the average person. Normally the next of kin gets the information first, and then a lot of the information, you know how information goes when it goes first hand and second hand and third hand. By the time you get to the fourth person,
they had one daughter,
there's a whole
and she
different
had already
story.
died, and the lady didn't got nobody, and she friend, if she had money, she would pay to get you. It broke my heart, so I called, because I know that I have a issue with my heart too, and I have to go to the hospital. Please clear the air, because that is what is going out.
Thank you very much.
On the other radio station. Do have a blessed day.
I appreciate that, and thank you for calling. It's something that we will address frontally very shortly.
So sometimes I get those calls. Somebody calls. They have a a friend of a family member who's in A&E, and the person, quote unquote, has been sitting down there for hours and hours and hasn't been seen. And then, when I investigate, they have been seen, they have been evaluated by multiple doctors, they have been admitted, and they're just waiting on a bed. And the thing about it, there's always that concern. They're waiting on the bed, and why haven't they gone upstairs yet? Unfortunately, beds can't be manufactured. There's only so much space the hospital has, unfortunately, emergency room ends up being overburdened because the hospital is full. Hospital is generally full.
But we're set to get some more beds shortly, about 50 more beds coming on stream, so you can look out for that. Look, Dr. Scantlebury, it's already our time. And I know we'll have to do this again, so you'll have to spend some more time with me taking you out of your clinic. I apologize for that, because I know you need to see your patients. But before you go, any final words for those out there who would have listened today, to things to look out for so that we can help them, because this is all about making people a bit more proactive in dealing with their health. Final words, final seconds.
Right. So remember those signs of heart failure and signs of a worsening heart failure status. So shortness of breath on exertion. If you have a diagnosis of heart failure and you find that you're getting more shorter breath than you were before, it needs to be targeted. You may need more diuretic, you may need more medication. Look at your salt intake. Avoid excessive salt, because that leads to fluid retention and heart failure presentations. If you're seeing that your ankles are swelling up and they weren't before, again, seek medical attention. Call your doctor, find out if you just need to take an additional dose of your Lasix therapy. But be proactive rather than retroactive, because a severe heart failure admission can actually land you in the ICU. So you want to take these things in hand early. And prevention of heart failure, let's remember, manage your blood pressure and your diabetes and your cholesterol and all of that stuff. A healthy diet and exercise to prevent the heart attacks and etc. and prevent it from coming in the first place.
Yeah, Dr. Scantlebury, we'll have to have you back to continue to preach what we are trying to do here, helping people to be a bit more proactive as far as their health is concerned. I really want to thank Kimberly for helping to manage the show today, and thank all of you for continuing to listen to us right here live on Q100.7 FM for the Pulse Radio Show. I'm Shane Seeley. I'll see you next week at 11 a.m. where we'll have another interesting discussion on how we can better help you take care of your health.
Pulse Radio Show brought to you with the kind compliments of MedSafe Medical Supplies.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
If you missed it, join us each and every Monday, 11 a.m. till 12 noon for the QEH Pulse Radio Show, and that special repeat each Monday night after our radio call-in program.